We are at 8 a.m., so welcome everybody. I believe this is our first grand rounds officially of fall, even though I think it's supposed to get into the 80s today here. But introducing Dr. Shapiro today will be Dr. Jen Weiss in our division of gastroenterology and hepatology. So Jen, take it away.
Thank you. I'm really excited for this talk. I think we've been planning it for a couple years now. So I just wanted to introduce you guys to Dr. Shapiro. So she has a BA from Cornell University, my alma mater, go Big Red, and an MD from George Washington University Medical School. Did her general surgery training at UCSD and her otolaryngology training at Harvard. And she is an associate professor in otolaryngology, head and neck surgery at Harvard Medical School. And just to kind of highlight some of the many accolades that she has in her CV, I wanted to mention that she has founded the Brigham and Women's Hospital Center for Professionalism and Peer Support in 2008, which was ahead of her time, as this is a very timely topic now. And it served as director for over 10 years. She was the chair of the Ethics and Professionalism Committee of the American Board of Medical Specialties. And in 2018, Harvard Medical School gave her the Shirley Driscoll Dean's Award for the advancement of women's careers. And what I really am excited about is I kind of came across the website that Dr. Shapiro has as I was looking for information just for myself about how do you deal with medical errors, because the longer we practice medicine, the more chance there is that someone is going to be involved in a medical error. And we really don't get great training on how to deal with it ourselves. So I saw a quote on the website that said, "Physician wellness is of paramount importance to our patients, to each of us as individuals, and to our profession." And that really struck me because I think especially the "to each of us as individuals" is very, very pertinent, and we have to take care of ourselves in order to be able to take good care of our patients. So I'm very excited for Dr. Shapiro's talk, and I also want to really encourage everyone to go to her website, joeshapiromd.com, creating a culture of trust and well-being in medicine. There are amazing support information about how we can support each other in this noble profession of medicine. Thank you, Dr. Shapiro.
Oh, thank you so much. It's really a pleasure to be here. I'm just going to put my slides up and make sure that works. Okay, how's that? Can you see them? Excellent. Wonderful. Yeah, it's just a delight to be with you all. I have no disclosures. These are the learning objectives. I put this title up because the strategy that we've used forever has been walk it off. Something bad happens, whether it's an error, which is pretty horrible, or patient workplace violence, or just stressful things that happen to patients. We've really taught ourselves and each other, and that's what we've been handed down through the years, is you just have to walk it off. And we know now that that just is not really a sustainable strategy in many instances. So that we're going to talk about how to address that from a certain perspective that I have and some experience that I have. I just want to thank your leaders and especially those who invited me. I really appreciate that, and highlight two of your colleagues in this organization, Mariah and Robin, who are really, have set up a peer support program. This is one of their slides, and I'm going to ask Mariah to just speak a little bit about this. But I just want to honor that you've got something great going here. And I've worked with Mariah for many years, and I just love working with her. Such a great leader. So I'm going to talk about the culture of medicine. I don't mean the culture at your organization or mine in particular. I mean the culture of medicine as a profession. And I've had the honor of an experience of working with different healthcare organizations across the U.S. and internationally. And I love the differences and regional different cultures, but I have found that there's a sort of through line of the culture of medicine as a profession. So that's what I'm going to be addressing, because I think for us to get better, we're going to have to look at some of the dark side, if you will, of our culture. But I just want to say, I could spend the whole time talking about how great medicine is, because it is. And I just want to say, one of the most beautiful things about this profession is that we're all healers, and nobody's going to take that from us. That is so solid. I think that to get better, to be better organizationally, team-wise, and individually, we have to look at like I said, the dark side. And I'm going to specifically talk about this part of our culture, that our system has treated us as inexhaustible resources, ignoring our physical, mental, and emotional health. Really problematic. And we've internalized this, which is really kind of hard to undo, if you will. This list could be longer. I'm sure you could add things to it, but we have acute stressors that are kind of unique to our profession: errors, adverse events not due to errors, communication with patients after adverse events, just emotionally stressful patient outcomes, things that we see really difficult things that happen to people, patient complaints, patient aggression, being reported to regulatory bodies, and of course, being named in a lawsuit. If you layer any of these on top of some chronic stressors like healthcare disparities, lack of our autonomy, corporatization of medicine, production pressure, kind of keep the volumes up, having our work be undervalued, doing our work with inadequate resources, isolation geographically, and then bullying, harassment, discrimination externally, but also from our own house of medicine. And then I just, cannot ignore, I'm sure none of you is, what's going on in the world right now, especially in our country, and some of the things that are affecting our colleagues and of course our patients. So the Institute for Healthcare Improvement calls what they're going for is joy in work. And if my view has been, if we're going to sustain that joy in work, we have lots of things we have to do, including fixing the EHR and all sorts of other things, but we also have to address these stressors. So I'm going to focus for our talk today on a specific stressor because I think it's one of the most difficult to bear, and that's when we've inadvertently harmed a patient. Again, it's not the most frequent thing that happens to us in our careers, of course not. But, as Dr. Weiss was saying, you are going to eventually have this as something that you confront in your career. So what do we know about the emotional impact of errors on clinicians? We know that we feel sad, somebody's suffering, and close on the heels of this we can have this sense of shame. And shame is where you go from saying, I feel terrible about this, and you add on to it, it happened because I'm not good enough. I'm not a good enough physician, fellow, nurse, pharmacist. And it can lead to this well-known described entity called imposter syndrome. And it's really, really a tough one. And I was always wondering, why are we so ashamed after, why is it so prominent? And I thought this study really illuminated something, which is where they looked at the similarities between aviation and medicine with regard to errors. And they found that both stress the need for perfection and a deep perception of personal invulnerability. That is, we're sort of taught we're supposed to not make errors, that errors come from being inadequate, not from, which, by the way, isn't true, but it's what we were taught. And so we have this idea that we're supposed to be perfect. Now, if that were something we could strive for, it was realistic, I'd be all in. Like, let's get perfect here, people. Let's remove errors from medicine. But I think from patient safety science that is an impossibility. Humans are wired to make errors. You cannot remove errors from any system anywhere. Because they're part of being human. It doesn't mean we should accept patient harm, but it won't be by zero errors. And that's a very big, different way of framing things. And we need to be doing things to prevent harm, and also to decrease the frequency of errors. So that's on us to do, but it's also on our system to anticipate errors and prevent them from reaching the patient. So it's a different framing, as I said. It was a picture I took, which shows the tagline of Boston Children's Hospital. I was at a stop sign, so it's okay. I was driving to work. And I thought, why are they saying, until every child is well? Are they, they're sort of setting us up in medicine to say, you bring your child to this, this hospital, and we'll make sure that child is well. And that's just not possible. And I think we have this mismatch between societal expectations and the reality of the work that we do. Also, we're called, healthcare heroes, especially around COVID, which feels good, and I'm not against it. But I also want to point out that it did, I think, set up this expectation that we didn't need as much sleep as other humans, and that we could be put in situations where we were not trained to or didn't have the proper PPE, and somehow we're heroes, so we needed to accept that. And I think that's really problematic. So shame, sure, is awful. Fear is real. What are the things that we're afraid of after we realize we've harmed a patient? What will happen then to that patient? What will happen to our reputation? What will your colleagues think of you and think of us? Will I get some kind of negative job consequence? And or will I be sued for this? In Japan, where I gave a talk at a couple safety conferences there last year. They were explaining how they are beginning to criminalize medical errors, which is unconscionable. So this is a study that looked at what happens to essentially reputationally, what happens to women surgeons compared to male surgeons after a patient dies. And they found that after a patient death, referrals to women surgeons decreased by 54%, where there was really no change in referrals to male surgeons. So this is an example of unconscious bias. But I put it up here just as a way to show you that reputational damage is real. And in this particular situation happens to be directed specifically towards women, but there's reputational damage in other areas regardless of gender. So we have a reason to fear reputational harm. So, I just ask you, by the way, thank you all for showing up for this. I think it's really amazing to kind of show up for things that are, you have a lot of other things you could be doing, but just to be here for your own professional development is wonderful. But question for you to just rhetorically think about. Did your organization send out an announcement stating, by the way, we're done with shame and blame here? I know that's the way we've done it here and the rest of medicine forever, but we think that's a bad thing, which is true. It is a bad thing. It leads to worse safety outcomes, but it's what we've always done. So we're going to stop doing it. And of course, nobody's organization sent out a memo like that. What we're going for is, of course, a safety culture, which is otherwise known as a just culture, where we have a learning mindset. Something bad happens, of course, we feel bad about it. And our job from that point forward is to make sure that we look at how it happened so that we can prevent it from happening again. So this is both personal accountability and systems accountability. It doesn't mean just blaming the system. It means looking at what could I have done and what learning do I need to do, or retraining or what have you, and also what should the system do. I would say, let's look at some of the internal and external regulatory processes that can come into play after a harm event. We've got event analysis like M&M, root cause analysis, patient safety committees, all sorts of different labels and different processes. Sometimes the Department of Public Health is called in. Other organizations have Health and Quality Safety Committee, Health and Disability Committee. In Japan, they have the Medical Accident Investigation. In the Netherlands, where I've worked, I worked for years to work on peer support. They have the inspectorate. In the UK, it's the Royal College of Physicians and Surgeons. The media sometimes gets involved, and then, of course, the medical legal system. So I put this up to say, look, lots of things may come into play after harm events. In theory and in practice, really, every one of them could be done with a safety culture framework, but they're not often, right? And so it's our job to take these processes and turn them into what we know leads to safer patient care. And that is a learning mindset and trying to understand this and prevent anything from happening in the future versus punishing those who were involved. All of these emotions that I talked about can lead to isolation and loneliness, which causes significant acute and chronic stress. So what I want to say about this is these are normal reactions, right? It's abnormal events that we in medicine are subject to. And, I would never want to raise a generation of clinicians that was like, meh, errors, they happen. No, I mean, of course we're going to feel bad because we care. And many times these reactions do fade over time. But the problem is sometimes recovery is thwarted, and this can cause significant harm. And there's a lot of data on this. I'm just going to pop up a couple things. We actually looked at physicians and nurses at the Brigham compared to a hospital in the UK, a mixed method study. And we looked at what some of the fallout was. And after medical error, and there were no differences between any of those four groups. After medical error, almost a third of people experienced some negative impact on work performance, personal life, colleague relationships. There is a known association between burnout and depression and major medical errors. And we know that there's a vicious cycle. If you've made a medical error, you have a higher chance of becoming burnt out. If you're burnt out from any cause, you have a higher chance of making a medical error. And very disturbingly, at least with physicians, the suicide ideology doubles, more than doubles after medical errors. So we wanted to look at, years ago, okay, well, how do we facilitate coping and resilience? And by the way, we should look at resilience. I want to take back this word that's, I think, been misused and remove it from the you should walk it off kind of camp into resilience means growth and learning through trauma. So how do we facilitate this? And we asked questions about lots of different scenarios, if you will, or stressors. But the graph I'm going to show you next was in response to the specific question, if you were involved in medical error, where would you want to get support from? And 88% wanted to be supported by a physician colleague. Certainly, we had great mental health professionals, employee assistance program, but the vast majority, this is what was their first choice. Another study, we looked at what facilitated coping and resilience after medical errors, and one of the factors was talking about it with colleagues. So we reasoned, let's start a program that actually gives healthcare providers what they're asking for, and that's the formal peer support program that I am highlighting today. It's on a spectrum, right, of support. So many of you, I'm sure, have either received or given informal peer support. Somebody sort of checks in with you. How are you doing? What's going on? I know it was a tough day yesterday, bad case, bad outcome, what have you. And that's a wonderful thing to do. The problem is those kinds of informal peer support interventions can be lacking for people who are really suffering, right? And they may be just left on the superficial level, and people's response when they're asked, how are you doing, might be something like, I'm fine, when they're not really fine. So there's nothing, I mean, informal peer support is great, but it may not be enough for some people in some situations. And so that's why we developed this formal peer support program that you also have your organization. I will also say that alone may be enough for some people. So instead of a quick check-in, it's like an hour of sitting down with a trained colleague who's trained to, just a frontline clinician, not a mental health provider, to sit with you and help you start to unpack what you're going through, and also begin the healing process, begin to strategize what's going to come next. How are you going to face this? So it's certainly more than informal peer support, but it's a one-off essentially. And so there's some people where they're going to need and want further professional resources. But we know that there are significant structural and cultural barriers to actually having certain groups, especially physicians, be willing to access further professional resources. And so one of the jobs in training peer supporters is to have them facilitate, first of all, destigmatize getting further help, and also help facilitate that happening. So that's where formal peer support sits in a spectrum. So, we were thinking a lot about, well, there's so many barriers to saying I'm hurting, right? I need help. Could we think of a way to make the program reach those who need it, but who would not be willing to self-identify as needing help? And so that's why, well, this was something we found in the study, these are the barriers, some of the barriers to actually seeking support. None of these are really particularly surprising, of course. This was something we wrote about in this New England Journal piece, which are kind of a way of summarizing the barriers to getting support, which is this idea that we have a culture of silence, which leads us to be isolated. This idea that we're always supposed to put other people's needs first, which most of the time in medicine, of course, we are, but there are times when that should not be the case. And that denying our own needs equals strength versus actually vulnerability is what's strength. Um, so given these barriers, we added to our program a reach out component where instead of waiting for people to say, I'm suffering, where can I get help? Because that doesn't happen frequently, although we hope the culture will change and that will happen more frequently. But in layering on this additional reach out proactively, we know something's happened, whether it's one of those other acute stressors or even chronic stressors that I listed in the beginning or an error, is that we reach out, have one person who's trained to reach out and say, look, I've been in this type of situation. It can really be hard. And sometimes some of us find it helpful to talk to a colleague. Is that something you'd like to do? So it's a very gentle reach out. You don't have to say yes. No one's pressured. It's just one person reaching out. And it takes the burden away from the individual clinician to seek help, or it lets us intervene, if you will, or offer intervention before there's actual stress manifestation. I just want to say how countercultural this is. I really think about it. We've had decades of the way we deal with these kinds of situations, whatever stressors there are, is we basically relied on individuals to just get back in the saddle, metaphorically, walk it off. It's part of your job. You signed up for this. Which, again, if that were sustainable, I'd be like, all right, I guess. But it isn't. All these bad outcomes, burnout, depression. I mean, this is really not okay that we've let this happen. But telling people now all of a sudden it's okay to be vulnerable, that's really a big change in culture. So that's why I think we've got to talk about this and model that it's okay to be vulnerable. And again, I'm not talking about like every day having a big debrief, we just don't have time for that, but never processing our own emotions and never showing our colleagues and our learners that we are affected by something and we're dealing with it. That's what I don't think is sustainable. So when should we offer peer support? Lots of the things I issued, I listed. I think you can offer peer support for anything. Um, I want to actually hand this over, if I could, Mariah. I know you're, Dr. Quinn, you're on the call. If you could talk a little bit about what you have here, specifically, you have a great graphic of the kinds of things that you're offering peer support for. Would you mind popping in for us?
Absolutely. Thank you so much, Joe. And thanks to all of you who are here. I got a chance to scroll through the participant list, and there are so many folks here who are active peer supporters, who are coaches, who are mentors, and just great colleagues. We have really a wonderful culture here and wonderful people here. We started the peer support program back in 2020 after a very successful pilot in our Department of Emergency Medicine, really at the time when we were anticipating a ton of extra needs for support during COVID-19, which, of course, still with us, but not in the same emergency sense it was at that time. And we really started out with our program focused on physicians and advanced practice providers and nurses. During COVID, we trained folks, many of whom are here, at least one of whom invited you to give this talk, to support their colleagues for all of the types of circumstances that you mentioned. Over time, we've sequentially expanded our program to include other professions and job roles within our health system and hold quarterly trainings. Our physicians get about a third of the support that our program offers, and year on year, the program has had sort of a linear growth in the number of peer support encounters that we do. But I would just also share that, Joe mentioned that sort of informal peer support between colleagues, which is just an absolutely incredibly important component of our culture. We find that those folks who get trained in peer support probably do even more of that than they did before they got trained. And so there's that sort of dual benefit to just kind of being in an environment with folks who are really watching out for their colleagues and a little bit trained to do it, and then that sort of more formal peer support. And we offer those same kinds of outreaches that you mentioned, Joe. I just will say that Joe trained me back in the day when I was in Boston before I moved to Wisconsin. And so we think very similarly about all of this. But any of these things on the slide can be a reason to reach out. The most common reasons that we get outreaches are medical errors or being convinced there was a medical error, which there isn't always when people have experienced an adverse event with a patient. We just take these things so seriously that we often blame ourselves, even if there was not a lot we could have done differently, in patient deaths. But there's a whole other host of reasons that people reach out. So thanks so much, Joe, for letting me pop in for a minute. Very appreciative.
Thanks for all you do and your team. It's wonderful. Did you want to comment on anything on this
Yeah.
slide too?
Yeah. So, you may have a love-hate relationship with the Pulse, but you can always find this information there. That's our health system intranet. If you search for peer support or the emotional well-being wheel, you'll find this. It's very easy to access peer support. One way you can do it is if you know someone who's a peer supporter, they might wear a peer support button. They may not. You may just know they are. You can reach out directly to them. You also can use our email, which is peersupport@uwhealth.org. It is a confidential email. Robin Valley Massey, who leads that program logistically, makes all the matches. She's incredibly responsive and kind. And I would really just encourage you to use that or to reach out directly. And if anyone has questions about peer support after this talk, I really am happy to answer them as well. Just email me.
Wonderful. Thank you so much. So what we're hoping is that in addition to helping individuals, that we're using a program like peer support to actually shift the culture away from the parts that are really dysfunctional towards the way we want to be. So helping us get away from shame and blame. And, just to pause here for a second, the reason we used to do shame and blame and that we're still kind of attached to it is we thought it actually would make the system safer. Like if we make you feel bad enough, make me feel bad enough that I made an error, that would somehow prevent my making another error. And I don't know how and other people watching that shame happen would say, okay, I won't make that error. But, errors happen. And we're not talking about errors where there was, risky or, negligent kind of stuff. But we're talking about where, human error, which is the vast majority of errors, which is the person who's the series of things that happened, were done with the idea that we think, we thought about this and we think this is the right thing to do. Turns out it wasn't, or we omitted something or just unaware of something. And so shame and blame does not make the system safer. For one thing, it discourages reporting. And the only chance you have of making the system safer going forward is if people are honest about what happened, or that something did happen, because it turns out a lot of errors are hidden from the people who need to know about them. So you've lost your opportunity to actually grow and learn personally, but also as a system. And we want to shift this shame and blame to a just culture, because that is the culture that actually results in a safer environment for patients. We want to move from this idea that you're supposed to be perfect, and people to understand that sadly we're not. And I will also mention something you may know, which is that medicine actually attracts perfectionists. And so many of us have a kind of at least somewhat of a streak of perfectionism, which is great can be really good, until it sort of comes back and bites you, because of this idea that, oh my gosh, I'm not perfect and therefore I'm devastated, I'm not worthy, and should I even continue doing this work? It really, the culture needs to emphasize what are the human factors that go into errors, because they're multiple and they're ways of decreasing their frequency. This expectation that nothing we see should hurt us because we're tough, we're strong, as a surgeon, this whole thing about like, just buck up and, put your head down, get your work done. It was just really, really a big part of how I was raised, trained. And I'm not saying it's just in surgery, but, obviously that's my personal experience. And people were not at all encouraged to say, hey, this hurts, this is tough. And what we understand, of course, it is tough, and we need to normalize those reactions. I think this idea, I think isolation, which is sort of underappreciated, how dangerous feeling isolated is. And I want to give you an example of a resident who came to me. I had the job of one of the associate DIO for Mass General Brigham for years. And this emergency medicine resident came to me, and she told me her story because she wanted to do something about this. And she said that she got more and more depressed in her her residency. And she came really close. She was riding her bicycle home, and she just thought very hard about, should I just lay down on the tracks here, the train tracks that I'm crossing? She got very close to dying by suicide and decided not to, and then got some help. But what she told me was she felt like she was the only person suffering. She just felt so inadequate and so alone. And together she was actually one of the people that we were sort of piloting and doing some of this peer support work with. She wanted to be involved in that because the idea was we want to be able to, as I say, normalize when people are suffering. And, so ironic that in medicine that we haven't prioritized any kind of self-healing or healing of each other. But I think we're getting better. I really do, especially, with the well-being movement, because that's, I think, been a huge, huge improvement. Again, isolation is just out and out dangerous. So this idea that self-care is selfish, which is, crazy, but it's certainly the way our training taught us. Understanding that self-care is essential. And again, I'm not talking about going to the spa every day, much as I'd love to do that. It's within perspective. Obviously, we're not going to be always taking care of ourselves, but to never do that, especially after significant acute and chronic stressors, that's again not sustainable. And I think if we're thinking about patient care, we need to realize what is shown in the literature, which is if we are not whole, if we are really suffering on some deep level, whether it's physical, emotional, or what have you, we are not good caregivers of others. We're just not. And so even if we didn't deserve to be nurtured and supported, if all you cared about was taking care of patients, that's the only priority you had, then you'd also have to care about individual well-being. And I also say, of course, we should care about ourselves as individuals and each other because we're human and deserving of care and support. You may have noticed that I don't use the term second victim. First of all, I don't like the term victim. I think it's very passive, things that are done to us, essentially. I mean, I like it for other situations, but not in this situation. What's really strongly pulled me away from ever using this term in these situations is the fact that many patient advocates I've worked with do not like it when we refer to ourselves as second victims after we have harmed them. They just feel, and here's a quote from an article that some patient advocates wrote: by using the term second victim, healthcare providers subtly promote the belief that patient harm is random, caused by bad luck, and simply not preventable. And they really take exception to our using this term. So to me, it's like, then we should stop using it. I co-authored with some multiple other authors an article where some of us, including Albert Wu, who wrote this amazing article years and years ago about the second victim, and it was a really important article. It was really seminal. It had people like wake up and say, when there's been a harm event, we have to think also about the providers involved. I think it was an important term at the time. My argument in the article is we should retire it, that his and others' argument are we should keep using it. So you can read it and decide for yourself. But I feel pretty strongly that the patient, as I say, patients do not like that. So I'm done with it, and I've been for a while. I wanted, before I do the last slide and leave plenty of time for people to react, I want to go back to what I said earlier, which is that how countercultural this is. Because when you just say this stuff that I'm saying, I think it's pretty obvious. Like, of course, we deserve support, and of course we should have help, access to help. And, why is this such a big deal? Why is it even hard to get these programs started? What's in the way of this? And why is it that reach out is so important? Why is there still such a barrier to reaching in and saying, I need help, please give it to me? And it's just this idea that you can't change a really embedded, internalized culture just by saying you're going to do that, right? So even the people who are working in patient safety who came out, years ago saying we've got to change to a safety culture, and in fact, it's required to measure your safety culture because it's found to be correlated with actual better patient care. That it's not something you can just snap your fingers and say, okay, we're switching over from this one culture to another. And so I want to point that out, and then I'm going to tell you a story, a true story, just to illustrate like how I think internalized this culture is, because I'll use myself as an example. So I think you could argue I'm a pretty big champion of well-being and, getting support and help, right? That's what I've devoted a lot of my career to. So here's the situation. My aunt lived in Manhattan, and we hadn't seen her since COVID. So my husband and I and my sister and brother-in-law said, like we've got to go see her, and so she's really an active person, world traveler, and really energetic. So she had us for the weekend, and she took us to a Broadway play. She wouldn't take taxis. We had to do the subway up and down the stairs, just walked all over the city, miles and miles, just an amazing time. So my husband and I stayed overnight. And in the morning, in her apartment, in the morning, she comes out of her bedroom into where we were sleeping in the living room. She said, something's wrong. And she sits down at the dining room table and she dies. And she just, her heart stopped. My husband's a pulmonologist. We had her on the floor. We tried to resuscitate her, but she literally just had died. And so why am I telling you this? And we took her to hospital. Everybody tried to revive her, but she really did die right in front of us. So this is a death that I would certainly sign up for it. Like, she would have been alone. We wouldn't have known how long she'd been there. We wouldn't have known if she'd suffered. We saw her, we were there. It was just amazing. And we knew that if she had a chance to live, it would have happened. And she did not. So in so many ways, this was like an ideal death. It's still hard to do CPR on your elderly aunt, but it was so grateful to be able to try, if you will. Okay, so I was scheduled the next day to do a virtual peer support training at UC Irvine, and so I contacted the person who was it was the GME head, who had invited me. And I said, look, this is what happened. So we're going to be in my aunt's apartment. I'm not sure how great the internet is. I'm still going to go forward and do the training. And she's like, why don't, you can cancel. And I was like, no, 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 I'm going to do it. Like, people are counting on this, and I'm going to do it. So I do the training. It was really stressful. It just the whole thing, but I did it, right? And I was scheduled the next day to do a second training and also do a big grand rounds on peer support. And so this a leader reached out to me. She texted me. She goes, I know you're a grown up and you can make your own decisions, but are you sure you don't want to cancel the next event? And I was like, I really do want to cancel. And then we kind of had a laugh at like how, I'm going to say hypocritical, but I'll say really knuckleheaded it was of me not to recognize like this would be a time when you put that down and you take care of yourself. Right. Of course I should have done that. But I had this, and I told my sister and my husband, everybody else, cancel your this, your that. And, this, but I was not going to cancel. And it just made me, I love to laugh at myself, to just laugh at like, oh my gosh, like I'm an expert in this. And I found it hard to say, this is a moment to say, it's time to just to take care of yourself. So I tell that story because, well, it's true, but also I think, we underestimate how embedded this culture is with our, our lack of being willing to get help. And also, the thing that I've noticed from doing a lot of peer support is how much clinicians blame themselves. And sometimes, as Dr. Quinn was saying, sometimes they calling something an error that wasn't. And I don't mean we shouldn't take personal responsibility or have feelings about it. Of course we should. I've said that earlier and I really mean it. But the degree of blame and harshness about ourselves is pretty extreme. Again, we don't want to shift to people who are like, well, it's not my fault, it's the system and I don't care. No, but we've got, so I mean, I don't think we're in danger of that. I really don't. From what I've seen over so many healthcare organizations, people really, really really are harsh on themselves. So I put that out to you just to remember when you're thinking about peer support and doing this work, which I think one of the reasons to have me speak on this, and you certainly have your incredible local leaders and experts, is just reminding us how much we need to push forward on changing the culture in a positive way without letting go of the sense of responsibility, but also saying, like, part of our responsibility is to each other, right? And to ourselves. And that will in turn have us do, a much better job at being compassionate and giving safe and high quality patient care. So I want to show you a slide. It comes from a tweet from, whatever it was called. I mean, whatever it's called now, an X. Okay. But it was a tweet years ago that had nothing to do with peer support from someone who's not in medicine at all. And I thought about it. Oh, God, it just hit me as like, yeah, this is really exactly relevant to this work. I dream of never being called resilient again in my life. I'm exhausted by strength. I want support. I want softness. I want ease. I want to be amongst kin, not patted on the back for how well I take a hit or for how many. Instead of hearing you are one of the most resilient people I know, I want to hear you are so loved, you are so cared for, you are genuinely covered. And I thought that's us, that is us at our best, and with peer support, encouraging that. Like I said, I want to take back the phrase resilient because I think it has come to mean in many people's minds not addressing our feelings, not showing vulnerability or experiencing vulnerability, but to think of it as like resilient in the sense of, can I grow from this? Can I move forward in a way that I heal, so I can move forward and continue to do the work that I'm meant to do. So what I'd like to do is stop and then encourage. Let me stop sharing, like just literally stop sharing, not figuratively. And I'm going to change my view. I just want to stop and give plenty of time for certainly questions. I mean, the format usually in grand rounds is, you're supposed to ask me a question, but I want to also invite and I'm happy to answer questions. But also I would invite anybody who wants to say, like, this is how I'm reacting to this. I don't think it's really realistic, or this seems great, or this part of this I don't understand, or is there a danger in doing this? Or, sure, but like, how are you feeling? And I would really, love to hear that. How does this sit with you, based on your experience, and your views on our culture? So also want to thank you for having me here, and leave plenty of time for discussion, including any pushback, any concerns, and any feelings.
Great. Well, thank you for sharing and for a wonderful talk and really thought-provoking. Maybe I'll start by, I was very, I really enjoyed sharing your story about how you reacted to family death. And my question is, many of us, and I would say this is something I do, is use work as kind of a refuge and a coping mechanism for other things that are going on in our lives. Is that productive, not productive? How do you balance that escapism into work and being focused on your work in order for you to help manage other things that are going on. Is that helpful or not helpful?
Well, it's a great question. Thank you for that. I'm going to say that I think, it's a very complicated thought that you have around this. And I have a couple of reactions. I think one is that um, I think it's really important to be able to, when you're working, to really be present. I really do. I mean, I don't think, people talking about, bringing home into work. Yes, in some ways, but of course, and vice versa, right? But you do need to be able to really focus. I mean, this whole thing about mindfulness and presence is real, right? You're going to do a better job if when you're doing, what you're doing, whether it's being home or being at work, you are fully focused there. Okay, so I think that's absolutely key. And I slightly worry about people saying, "Oh no, you're always going to be mixing both things." It's like, no, not really. Actually, you're not, or you shouldn't. The same way, like we say we can multitask, but actually, no, you're just degrading each task that you do when you switch back and forth. It's sort of a similar analogy. So I think the presence and focus is really key. And I think um, this idea, but second thing that you brought up is this idea of, well, sometimes actually being at work helps us actually cope with things. So what I would say is if it helps you cope with the thing that's bothering you, right? That's work related, that's fine. So this comes up with this idea of like, should we tell people who have, let's say, been involved in an error, providers in an error, you have to go home. Like you got to come offline. This is what they do for first responders. You're offline. You've seen something horrible. I don't care if you think you're fine. You are coming offline. And there are healthcare organizations that actually make you leave if there's been some catastrophic event. So the problem I have with doing that is there are some people where they need to still be at work. That is going to help them begin to cope and maybe even distract their mind from the going over and over and over, obsessing about something that happened. So that I think it should be offered that it's okay if if it would be good for you to go ahead and, leave. But if it wouldn't, you can stay, right? Understanding that there is some risk to that you want to make sure you're not distracted while you're working by these thoughts, et cetera. So I think it's a layered, nuanced question. I think it should be up to the individual, but also the system should acknowledge that it's okay. I'm going to give you an example. There was an event where a patient was helicoptered in. She had serious partum bleeding. I mean, it was massive. And by the time she got to our hospital, it was pretty much it wasn't going to work. And they had teams, vascular and OBGYN, all working on the patient. She died, on the table. And what we did was we offered the person who was really in charge of that case was the one of the vascular surgeons. And we said to her, she had a whole caseload to go through. Do you want to leave? Because we can cancel your cases, right? I mean, of course we can. And she said, I just want to dive back in. I feel I can concentrate. And she goes, I'll process this afterwards. And so she did, and that was her choice. So I think it should be a choice. And it often is not, by the way. And so I think it can be very functional to use work to distract and be present for that. But one thing that you said that I would not worry about, but I say is a little bit different is if you're really having stuff at home that's problematic and you're using work to escape dealing with that problem, that's probably not a good idea because that problem isn't going to go away. But I don't think that's exactly what you meant, but I just wanted to say escape in that way. No, probably not functional, but escape in the sense of get distracted so that you can, distracted from what's really upsetting you at work so that you focus on work and then you can do your healing another
Yeah.
time.
Yeah, I've had people who are, trying to process really, bad things say, I need to be at work and focus on work because otherwise I am just at home spinning things in my mind and
And that's okay. Like, in other words, if that's, to the surface of like, this is helpful for me now, right? You'd also wonder, like, are there things that, are you also attending to what's, when you are home, are you attending to things you need to do? So, and I love your question for so many reasons, but one of the things that comes out most frequently for me when I'm doing peer support, from, what I hear from peers is that they're obsessing about what happened. They're going over and over and over the event. And so I teach this sort of mini mindfulness technique of acknowledging when that's happening, like, oh, I'm obsessing about this. Hey, that's normal. That's what we do because we're wired to kind of go over and over difficult things. It's normal, right? Acknowledge it, and then gently, smile inwardly and gently bring your attention back to your breathing or something else. So this giving people this strategy of how do you deal with that obsessing? And to your point, one of them is distracting by going to work, and that's okay. That's okay. You do it. I'm doing it. It's not, I'm not able now when I'm sitting at home to actually do anything productive. I'm just obsessing. Hey, may as well, do what you can do to stop obsessing.
Great. And I do want to get to it. There's a number of questions and comments. So one specific question, you mentioned M&Ms as a way that we review medical errors. Do you think that is a good mechanism? Does it help normalize errors, or is it a little too much? Has it been shame and blame?
That's also an interesting question. I actually co-authored an article about this because we looked at all of the places, and we did it when I was at the Brigham, for the Brigham itself, where all the places where discussion of errors happen, right? Whether it's like educational conferences, M&M, where do these happen departmentally, divisionally, et cetera. And so, M&M is obviously a very important place. I think there's two issues with M&M. First, I think M&M is a great place to do it, but there's two issues with M&M that need to be addressed. One is the history of it. It was absolutely shame and blame. I mean, hey, I'm a surgeon. It was like, oh no. And it was not only just shame and blame, it was just often towards the trainee who wasn't even making the decisions, right? And the faculty sitting there and the people like, how could you possibly? And the other attendings are kind of, like, you want to be like, I did not decide to do this, but that's not the way it was. You took the hit and you were proud to stand up and take the bullet for the attending and all that stuff. Okay, so that doesn't work, right? Same reason shame and blame has been shown to be an anti-safety maneuver. We also saw from the study, but I also know I'm married to an internist, and I have a lot of friends who are in internal medicine, is that there were very few places within medicine that actually were doing kind of hard-hitting looking at errors and even learning from them. That usually case conferences, these educational conferences were, and I know it's changed, but this has been the history. I'm just talking about history of both. It's been like, oh, let's look at this fascinoma and talk about all the literature, but not like, let's go over in the past month these, things that happened that we need to learn from. It just wasn't part of the culture, right? And some people have argued that with M&M, even like full out M&M, that it's actually gone so far the other way where nobody's willing to say, look, I shouldn't have done this. Here's why I chose to do it, but I'm never going to do it again. And hey, what do you think? Have you seen this? And ideally, that's what happens at M&M is you say what you think you should have done differently or why you chose it, and you would still defend doing it again. And you have other people weigh in on, I've seen this before, but I wouldn't use that approach. Here's why. That's ideally what M&M should be. So I'll just tell you that when I used to run M&M for my division, I actually said, I said, we're going to have a mantra at the beginning of, it was monthly, every M&M. And that is, we are sitting here now to learn. We're not here to say how stupid I was or you were or what have you. We are here to learn, and that will involve both on a personal level and on a systems level. That's our goal. And I said it every single M&M because I needed to remind people that's where, that is why we're here. Because I think sometimes a discussion would get just too superficial, like, oh, we see this. It's like, well, yeah, I know we see this, but like, is there anything we could have learned about this? That's what I really want to explore. So, I kind of been, evangelical around this idea of M&Ms can be phenomenal. if they're done in the right way. And the last problem with M&Ms, which can be actually circumvented, is they often don't result in systems changes because only parts of the system are there, right? There's no other specialties, or there's no nurses there that, and so it's good for certain things, but it needs to have something that lets any systems issues move forward to people who can actually look at the system, or maybe call a multi-D kind of analysis of what happened. So I think it has its limitations, but I think it's a fantastic place to actually start to to destigmatize. Like, we're going to talk about this, and I'm going to show you that I did this, and I don't feel good about it, but here's why I chose it. Help me learn from you all.
Great. And Jen, did you want to add anything?
Yeah, so this was actually, so Dr. Keixo is the one who asked this question, but I was going to ask the exact same question, because as far as like the reactions, when I was an intern, it was the old M&M style, like you were talking about, and I still remember standing up in front of the entire auditorium, with everybody in the Department of Medicine and faculty sitting before me and standing there and presenting the case and having to answer the questions that they were asking me. And I mean, I still remember that. That was, I don't even want to say how many years ago. And I will say that now, and I kind of want to promote what we do in our GI division. So the way we do it now, which I think is actually fabulous, is we call it quality assurance. We do it every quarter. And the person who was involved in the case is not necessarily the one presenting it. It is the faculty member that's in charge of quality assurance gathers up the cases that we want to talk about, and they present the case. And so it's the person who's potentially involved has a little less, I think, emotional vulnerability, because someone else is presenting the case from the perspective of how do we learn from this. And it's the same thing that I think you were talking about, Dr. Shapiro. We look at it as, even if it's something we see all the time, what happened in this case, what could have been done a little differently. And I think we actually have had quite a bit of systems change that has process change that has come from it within the GI division. And so just seeing the difference in how the M&M type quality assurance reviews have changed over time, I think has been incredible.
That's great. Thank you for adding that. That's wonderful.
Great. Another question from Dr. Wazinski. How do we change the narrative at a societal level about this expectation that your physician should be available 24/7? And I think it's even more exacerbated now with this expectation of immediate return. Like, I should be able to send a MyChart message and get a response like within 5 minutes. So thoughts on that?
Yeah, I think it does speak to the issues about societal expectations. How do you get around those? Changing your logo might be a good idea if you're a children's hospital. They do still use that. I'm like, why? So I really think these expectations have to be addressed straight on at the outset. This is how the practice works. This is how we do it. We have guardrails that we're not going to change it. We're not going to accommodate because you think it's the right thing. It's this is how we do it. Being very clear about what will happen if, people try to abuse the system, how we're going to handle that. But I think, if you look at, at least this is my experience with Epic, is they're pretty clear when you put in a question that it's not going to be answered right away unless it's an emergency, and then they're telling you what to do. So I think that conversation has to be hardwired within how we have our patients communicate with us, but also it has to be stated as an expectation with every patient. Here's how we work things, and it kind of reminds me of it is amazing that people will what they expect of us, but I think also to be compassionate towards patients, they don't understand. They really think, they just don't get it. They're not doing it to be horrible, but it's really about the impact, which is it's unreasonable. So I think being compassionate about explaining, I understand you want this done, but this is our system, and this is the way we do it all across the system, being very clear. I was going to say that, actually I want to tell a story. It was about when I worked in Africa, was, how they said to, like, we're not on call for these nights because we can't be on call every night, kind of thing. And it's set up the expectation, like, it's just the way it is. Doesn't feel good to that person at that time, but sorry, we got, this has to be sustainable.
Great. And then finally, a comment from Dr. Trowbridge talking about the isolation and COVID really had an impact on isolation, and I don't think we have recovered from that and reconnected. Any thoughts or recommendations of how to improve connectivity in the post-COVID era?
It's a huge question. Yeah, I think a lot of people are
1
wrestling.
minute to go.
Yeah, yeah. Okay, here's how to do it. I just think, first of all, you're calling it out is the beginning for sure, is just saying this is a problem. Because I'm going to tell you, I think, when we talk about like what makes work wonderful, it's a sense of community. And we've lost that. And part of it we lost is like people are like, I'm going to come into work and then I'm out of here. Which, I mean, I feel the same way. I get that. But it's also like there are things that we could do that yes, it won't let us go home right away or something, but it's still worth doing. So, I mean, I can tell you what some organizations have done, and they've measured some good things, is they have, like, for example, physician groups that, they'll go to dinner, once a quarter, just a bunch to different physicians, and the organization has supported that as a well-being effort. It's really successful. Anything that puts us back in community, encouraging, like, I just think we have to see each other on occasion face to face, and it will be, in some ways, we will sacrifice a little bit about get out of the hospital and those, once a quarter, let's say, for example, but it's worth it because it makes, you start to see that you are part of a community. And the other thing is you can create community and maintain that community virtually too. You can set up meetings where you're just doing a check-in with each other with this group that said, we're going to stay together. We used to do it with the peer supporters. We kept that sense of community. We did dinners every quarter in the hospital, like, it's just a nice catered dinner. And then, okay, we stopped doing that with COVID, but then we still had people meet virtually as a group, right? And I think that's really important. So you can do it both ways, but I think you have to say we're going to have this time together that is about reconnecting. And I often, yes, so I was just going to say, I often get asked to do a talk where the medical staff is at, I just did this for a hospital locally where they were having an event, a dinner event for the medical staff. And they asked me to do a talk there. And it was like they were social connecting with each other. It was just they just talk about how much of a sense of community they have. So I think we have to do that. I think we know what to do. It's just like actually doing it.
So with that, that's a perfect end note. I will remind everybody our October 10th Grand Rounds is in person. So remind you, the second Friday of the month in person. It's a great way to reconnect with community. We provide some breakfast. We will validate your parking. And as a reminder, we are highlighting Artist of the Month.